Welcome back to the Miraculous Mamas podcast. We believe in empowering people through story and education. I'm so glad that you were here. If you guys didn't catch last week's episode, it was with Tatiana from ICANN talking all about cesarean birth and VBACs and your rights in labor. It was a great episode. April is C-section Awareness Month, so we just wanted to get some information out about that. This week I have Dr. Tracy Tran on, and she is a pediatric dentist, and I was super excited for my conversation with her to talk all about tongue and lip ties. As you guys know, Jovi had both, and it's a hard decision to make as a mom to know what to do. Obviously, it depends on the severity of the tie and if it's affecting their eating and stuff like that. So I just had a great conversation with her. If you can hear Jovi, she's here right now. She wanted to say her piece on that. So yeah, I'm super excited for you guys to hear from her. We do dive into the science, go into detail. I feel like we talked for like an hour and I still had so many questions. As soon as we hung up, I'm like, oh, I should have asked this and that, but there's still a lot of great information in the episode. I'll maybe have to have her back on to talk more about it. I just find the subject super fascinating. So we're going to go ahead and dive right into the interview. All right, everyone, I have Dr. Tracy Tran here, and I'm so excited to talk to her because she's a board-certified pediatric dentist, and I'm really, really fascinated with all things that go along with that because my daughter had a tongue and a lip tie, and it's just so hard being new parents, knowing if you're making the right decisions, what to do, and then you learn how it could affect all these crazy things later on in life. So I'm so excited for you to come on and to help educate the listeners and to share with us exactly what you do. So thank you so much for being here.
Thank you for having me. I'm really excited to be here, and I love trying to help parents out in any way I can. So
yeah.
Whatever knowledge I can.
Yeah. So how did you get into the pediatric dentist world?
I've always loved dentistry, and working with children was not something I knew was a specialty until I got into dental school. But I have a heart for kids. I love them. I grew up with tons of kids around me and little cousins, and always taking care of them, especially the babies, actually. And it's always fun to be able to help a child get through a very stressful situation, which dentistry tends to be for a lot of people. So it's always rewarding for me to be able to do that. So that's kind of how I got into pediatrics, and very good at working with my hands, and that's how dentistry kind of worked out for me, caring for people and working with my hands. It works.
Yeah. Well, like you said, it can kind of be stressful for a lot of kids. I have like a traumatic childhood dentistry story.
What happened?
All I remember is when I had to have been like 5 years old. And I just remember the dentist saying, Elizabeth, you have to stop screaming. You're scaring the other patients. And I don't remember what was happening or what was going on, but I just remember I was terrified.
Oh,
I know.
That is the hardest. I always feel for kids because they're in their own head always. And it's fun for me to be able to talk them down and just like bring them back. It's okay. Let's back. Let's start over. And I think a lot of fear just comes from not knowing what to expect. So I just prepare them for every moment, every sensation, every little thing that might be startling to them. And when they know ahead of time, generally most kids want to help. They're all very much pleasers and they want to do a good job and reward them, lots of positive reinforcement, and they get prizes when they leave. So
yeah,
it makes it for them.
Yeah. So I'd love to just kind of jump into the whole tongue and lip tie world because I feel like it is something that you hear more and more about. And I've even heard people say that it's a trend, or that, kind of our makeup has changed to where it is happening more. And I guess I don't know the answers, so I'm hoping you do.
Well, it's interesting. A lot of people want to say that it's a trend, but tongue and lip tie has been present for an extremely long time. Back in the day, midwives would have a long pinky nail, and when they would deliver the babies, they would check for their tongue and lip, and they would just swipe their pinky nail and get rid of the tie. So they knew that this could impede feeding on breast. And then eventually industrialization, bottles, formula came around, and women started working more. And the bottle was convenient. So I think there was a very long period of time where breastfeeding was not as important or thought to be as important. So it kind of got lost. And babies sucking on the bottle and feeding on the bottle is way easier than being on the breast. So finding that there's an issue with feeding, you're not going to find it oftentimes on the bottle. So this has been a non-issue for so long. But nowadays, I guess if you want to say it's a trend or that breastfeeding is a trend, that has become more popular amongst moms. They're a lot more committed to breastfeeding. And when there's something that's off to moms, they're going to search for answers. And that's what's been happening. They're looking for answers as to why their baby won't latch, why they can't feed. And it makes sense. There's so many benefits to breastfeeding and having breast milk. The benefits to breast milk is obviously for the immune system. It helps a lot with that and the nutrition, nourishment that they get from it. But there's so many benefits to breastfeeding when it comes to growth and development of the face, the oral facial structure. And that's where myself as a dentist comes in. And I find so much interest in getting them to not just breastfeed, but to breastfeed properly, the right way, efficiently, effectively. So when a baby's lip or tongue tied, that definitely impedes their ability to do it well. And that's I think what tends to be what's difficult for pediatricians or lactation consultants or people who don't really look at tongue and lip tie. They're looking for weight gain and seeing that the baby is latching at all. To them, that's okay. But oftentimes when mothers are coming to me, there's usually something small that's off and they're not sure what it is. And it's very vague symptoms like, well, they're feeding really frequently and they're not feeding for long and they're falling asleep on the breast and they're not sleeping well and they're colicky. And these are all symptoms that can be caused by so many different things. So tongue and lip tie gets overlooked when it tends to be the underlying problem. So
that's so interesting. This episode is sponsored by Apostrophe, a prescription skincare company for people that are ready to take their skincare needs seriously. Prescription acne treatment really works and it can be hard to get. You can also have to take time off work and see a doctor, sit in line at a pharmacy for your medications until Apostrophe. Apostrophe makes it easy to see a board-certified dermatologist online. You'll get treated immediately and your medications are delivered right to your door. All you do is simply fill out Apostrophe's online questionnaire about your skin. You send in some snapshots of yourself and wait for your dermatologist to get back to you. The best part is that they offer topical and oral medications so you can treat your skincare needs from the inside out. And I used it for my rosacea actually on my cheeks. So I've dealt with, it came out of nowhere. So I get melasma on my upper lip and then rosacea. So my skin tone has just been completely uneven for probably 7 years now. And so it's something that I've been really self-conscious about and I've tried a lot of different things. And so I decided to get a prescription for it. And it was super easy to just send in the pictures on Apostrophe and have them get back to me and me be like, yeah, that sounds like a good skincare plan. So it's really cool how they have it set up. And then they send it in this cute little box that I got and a poster card to tell me like how to use it and what to do. And it's actually been working. I'll have to show you guys a photo on Instagram. So right now you guys can get $15 off your first visit with a board-certified dermatologist at apostrophe.com/mamas and use our code mamas. This code is only available to our listeners. To get started, just go to apostrophe.com/mamas and click begin visit, then use the code mamas at sign up and you'll get $15 off your dermatology visit. That's apostrophe.com/mamas and use code mamas to get your dermatology visit for $15 off. And we thank Apostrophe for sponsoring the podcast. I know in my experience, so my daughter ate like a champion, and latched and all of that, but the latch was painful. Like she was like just on the tip of my nipple, basically. Like my nipples were like flat, had that like white line in the middle, just not latching properly. And honestly, I wouldn't have known especially since she was gaining weight and doing all of that. But, the pediatrician just kind of mentioned in passing, like, oh, it looks like she has a thickened frenulum, so you might want to just check that out. And then the lactation consultant was like, yeah, I would definitely, have somebody look at it. So, I went along with it, and
that's great that they recognized it and they told you.
Because I never would have known. But then I feel like when you dive into the world of the ties, it's so much more than just feeding issues. So I'd love to kind of talk about, how it can affect them in infancy and then how it can trickle into like different areas later in life.
Yeah, absolutely. Obviously, breastfeeding is the one thing that babies have to do. So it's an early sign of improper function. And that's what I do with my assessment. I'm looking at function. How good are they at performing the functions that the tongue is supposed to perform? And I always tell my patients it's going to be suck and swallow for an infant. And then eventually it'll be speech as they grow older. And then the other thing is with breathing and sleep. So those are the key things that I will look at as they grow and develop will be affected by having a tongue and lip tie. And the reason being has to do with where the tongue is supposed to be postured, and that's up against the roof of the mouth. If it's tied, it has a tendency to stay low. And when it stays low, when a baby breastfeeds, this is the earliest sign of it, they have to open really wide, get the breast tissue deep in there, and the tongue has to press the breast tissue up against the palate in order to transfer the milk, and that's how they do their sucking motion. If the tongue stays low and they're not able to press the breast tissue up, one of the things that they're not doing in assisting in their growth and development is expanding the upper jaw, the palate, the roof of the mouth. So the palate is actually in two pieces. It's like, how infants have soft spots on their head. They also have a soft spot on their palate right in the middle. And that palate in the two halves that it's in, when the tongue presses the breast tissue up, it actually presses up against the palate and helps it to spread. The tongue resting up against the roof of the mouth also assists in helping that palate to spread. And we actually know through studies and research that happens really early on in life in utero already. So oftentimes when a baby's born and they're tongue-tied, we already see a very narrow jaw and a very high palate. So we know that the development has been interrupted. If that continues on in life, if we don't address the tongue and lip tying, we're not addressing the posture of the tongue, the palate continues to stay narrow. And we know now, orthodontists, we're expanding children all the time because their palates aren't expanding. And that turns into sleep and breathing issues because the palate, the roof of the mouth, is the floor of the nose. So if that doesn't widen out, neither does the nasal cavity. Now we've got a breathing issue. Speech, feeding and swallowing is the other one. When they're around 2 or 3 years old, it's not always affected because the tongue compensates really well. It moves in so many different directions. and it's got muscles that go in different directions. And so it can extend, it can retract, it can lateralize, moving side to side. Kids will figure it out. They'll find some way to produce sounds and to be able to talk, because communication is necessary, but they might not be able to do it well. One of the rare things that does happen is speech delay in a young child, like 2.5, 3 years old. I've had kids that I've had to put to sleep and release their tongue tie. I was kind of against it at first, but I had some moms convince me to do it, because there's always risks to putting children to sleep, especially at that young of an age. But, if I didn't experience what I experienced with those children, with mothers who were very adamant about doing it and understanding the risks, I wouldn't have seen the benefits of it. And some children I've done tongue tie releases for, and a couple days later, they're talking. And they weren't talking before, or they were constantly drooling and then they stopped drooling, which makes sense because the swallow, if the tongue's not working, the swallow's affected. And so they're not going to automatically swallow their saliva. So there's so many little things that can come up, and they often get overlooked. And it's because of having just a poor understanding of function itself. And the people who know those things are going to be our speech language pathologists and occupational therapists who do oral motor therapy. They know the most. And those are the people that have taught me about function. And that's how I've incorporated it into what I do when I'm assessing an infant with lip and tongue tie.
Mm-hmm. And those are people that you also, like, if my pediatrician hadn't mentioned anything, I wouldn't my daughter's 6 months old, and I really have no reason to go see any of those people, or even a pediatric dentist. So I wouldn't even know until later, maybe, if an issue popped up from it.
Right. Yeah. That's why getting the word out and helping moms to understand this, families to understand this, is a big deal, because so many moms struggle for so long not knowing it. And sometimes it's not even like the struggle. Your struggle was with pain. Sometimes it's not pain. Sometimes it's sleep. Mm-hmm. The baby's not feeding well, or they're having to, moms think, they cluster feed. They want to cluster feed all the time. But it's because they're never getting enough in one feeding, because they can't efficiently suck and swallow, that they end up just feeding a little bit, getting tired, falling asleep, expending too much energy. And then they sleep, and then they wake up 45 minutes later, hungry again. And these moms don't get any time to themselves, and they don't get any sleep because they're constantly feeding their baby around the clock. And they're so committed to breastfeeding. And it's hard because it can affect them psychologically, because, sometimes a pediatrician who might not know will say, well, give them the bottle. And then they end up on the bottle. And the moms get sad, and it can really generate some postpartum anxiety or depression for some mothers, because they're not able to do what they feel like they should be able to do for their baby. And so that becomes another component of what I do, is recognizing when that's present and offering moms that sort of support when they need it.
Mm-hmm. All right. We are going to take a quick break. So I can tell you about one way that I like to de-stress a little bit. Life can have its little annoyances. Like for me this week, it's been cleaning baby poop out of a bathtub a few times, cleaning it off of the blanket and off of my clothes. I don't understand how this happens. When you have kids, it just gets everywhere. And a lot of spit up. So, one way that I like to just unwind and blow off some steam is playing the game Best Fiends. It is the top-rated mobile puzzle adventure game. I like it because I am competitive. So whenever I pass somebody in a level that I know, because you can connect with friends there, it just fuels me to keep going, because I love a little friendly competition. And, right now I'm not seeing a lot of people. So it's nice to have Best Fiends to compete against some of my friends. And it's also nice to just have a way to unwind. You also can compete with yourself. Well, for me, because I'm competitive, gaining more characters, advancing more levels. I am in the thousands right now. And you know what? I thought maybe they would run out of levels, but they have not. So it's just fun to be able to de-stress that way. And they're always changing things up on there. There's always, like I said, new levels right now. Like they just keep adding more. And they have different themes. So every single month there's new themes. There's different challenges for you to participate in if you want to. And it's just a great way to blow off some steam and, just kind of engage your mind in some puzzle. I know dealing with kids all day, sometimes you just want something a little bit different. So don't blame us if you end up being kind of obsessed with it. Download Best Fiends free today on the Apple App Store or Google Play. That's Friends without the R, Best Fiends. Now back to the episode. So sleep. So when does that usually show up? If it's not the cluster feeding when they're young, like as they start getting older, that whole, how you said,
as the palate expands or as they develop. Yeah, it's a lot. It's hard for me to explain without showing diagrams and showing what the anatomy looks like in the airway. But just imagine, it has to do with what healthy breathing is. So healthy breathing. Do you know what healthy breathing is?
No.
So healthy breathing is nasal breathing through your nose. When we breathe through our nose, we're producing something called nitric oxide. And that nitric oxide binds oxygen more readily. And it circulates throughout our body and helps to deliver oxygen more readily to our organs. So we're essentially oxygenating the rest of our body more efficiently by producing nitric oxide. The other thing that nasal breathing does is it humidifies the nose, keeps it moist the way that it's supposed to. And the nose has special filters in it that helps to clean the air. So we're supposed to breathe through our nose. It's meant to filter the air. It's meant for all these healthy benefits. And when we mouth breathe, we don't get those benefits. The nose gets dry. You can end up producing more mucus and having sinus issues. So some people end up with congestion. And I actually see this in babies too that are mouth breathing. They tend to have more congestion. And then when they mouth breathe, instead of the nose filtering the air, now it's the tonsils. The tonsils will get big. They end up, the jaw drops open. The tongue stays low. The upper jaw doesn't expand. And then as the jaw drops, it also affects how much oxygen they're getting and how efficiently they're oxygenating. And then as the development continues, as they get older, these problems compound. Now, all of a sudden, the mouth breathing, if it's happening more regularly, the face doesn't get to grow the way it's supposed to. You don't get expansion. It starts to elongate, and it just gets worse over time. It gets worse. And then the tongue, when it stays low, it doesn't just stay low. It also gets pushed back. The upper and lower jaw don't get to grow forward. It's the house for the tongue. Now the tongue doesn't have any space, and you end up having more chance of airway collapse, which is when towards the back of the mouth, at the base of the tongue, there's a lot of soft tissue. And when you breathe inward, it will collapse on itself. And so sometimes it doesn't fully collapse. Airway collapse is like when you're sleeping. If you breathe inward and the airway collapses, that's when you stop breathing. That's sleep apnea. Sometimes it's just the airway closes and it gets smaller. You have more resistance. So when you breathe inward, you have to work a lot harder. And that airway resistance, we call it upper airway resistance syndrome. And so rather than getting like 100% oxygenation, maybe you get like 95, 90, maybe less than that throughout the night. And that when we know that when oxygen saturation drops below 95%, you have oxygen deprivation to the brain. And so if you imagine a child that has upper airway resistance syndrome and not getting enough oxygen to the brain, that's when most of our development happens, is in our sleep. And so that affects not just, their growth and development with, physical growth and development, and like for it being unhealthy, it also affects their cognitive and behavioral. So there's a lot of neurobehavioral consequences to not breathing well. And when there's a tongue tie, that can be like just the start of the issue. And then all these other problems develop from that. So I don't like to scare parents because it sounds scary, but I like to let them know like this could be, and this likely is the trajectory. And oftentimes when I explain this, the parents start to think about themselves. They're like, actually, this is how I am in my sleep. I mouth breathe. Is this why I'm always sick? Is this why I have these sinus issues? Is this why I'm always tired? They start to think about it, and then they're like, okay, we really want to do something now, because they recognize what kind of quality of life their child can develop into. So,
Is there a benefit then? Let's say it's been 30 years and you've been mouth breathing your whole life. Is there a benefit to like getting a release when you're older, or is it like everything's already developed, so you're not really doing anything?
It's a hard question to answer, because just like I tell every parent, I'm like, listen, we can do this, but I'm not going to promise that we're going to fix or prevent all these problems. There's still a strong genetic component to it too. But, we all compensate differently. So I don't know what this child is going to experience. I know how they're going to grow, how their bones are going to grow in their face, but I don't know what symptoms they're going to experience. I can guess the major ones. But so for an adult, same thing. I don't know how bad their symptoms are and how much effort and work they want to put into making it better. And so it does get more involved the older you get. And so for an adult who wants to fix this problem, if they're tongue-tied, the tongue tie is the underlying issue. But if there's no space in the mouth for the tongue, then you have to create space. So if you want to fix the tongue tie, you got to create space for it. And to create space for it for an adult usually requires surgery, expanding the palate, making the mouth wider. You have to do surgery. It's like really the only way. You have to grow the bone, make it wider, and make space for it. And so when I tell parents that that's what we have to do for an adult, and then they need a lot of therapy, myofunctional therapy, to relearn new muscle patterns and to strengthen the tongue and get them to use it the way they never did, that's typically what they have to do. Now, sometimes the structure is not as bad as it might be. And so sometimes, we can fix the tongue tie and they might have some benefits to it. Now, I don't treat adults. I just hear about it from my colleagues, and my colleagues at the Breathe Institute. They do a ton of research in this. Dr. Zaghi would be a great person to talk to about this because he's the ENT there that does the lip and tongue ties, and he has a team of people that he works with, an oral surgeon, Dr. Kevin Koppelson, and some orthodontists to make space for adults before they do the tongue tie release. So
that sounds like a huge intervention.
It is, and it's very costly too. It can be very expensive. When you're talking about facial surgery, craniofacial surgery, it's expensive. And so we're talking like tens of thousands of dollars. But for children, sometimes the treatment, doing orthodontic treatment and treating a child with sleep disorder breathing and sleep apnea and modifying their growth to make space for the tongue, I do that for them. And there's a few other pediatric dentists in the Los Angeles area that I work with. Dr. Audrey Yoon, she's actually a pediatric orthodontist. She's dual certified, and she does a ton of research with Stanford in this. And even though it might cost a few $1,000s to do this, it's still not much compared to the tens of thousands of dollars you would spend as an adult to fix this problem. So I'm all about helping them grow better, helping them breathe better, helping them function better. And I always approach it with a team of people. The older they get, the more they need on their team. But, I'm actually going to take that back, because even for infants, they need a lot of people on their team. Whenever I do a tongue tie release, you have to think of it as it's a feeding problem. And whenever there's a feeding problem in a baby, it's really hard to determine. It's not like the baby can talk to you and tell you, this is my problem, this is what I'm feeling. You kind of have to look at them and see how they're responding to certain things. And in babies, what we're looking at is we're always looking at reflexes. What's their reflex? When I tickle the bottom of their lip, does their tongue extend? When I put my finger in the back of the jaw, do they bite up and down? Some babies are born with very weak, low muscle tone, poor function, and I have to have them work with somebody who does oral motor therapy to get them to function and have more strength and endurance in their muscles of the face and tongue before I do a tongue tie release, especially when there's a posterior tie. And that's like a whole nother thing.
What, can you just explain what that is super quick?
Yeah, of course. So, and you'll hear this, and I don't really like to call it posterior tie, but there's anterior tie and posterior tie. So anterior tie is when it's an obvious one. There's a frenulum at the tip of the tongue, and you can see that it's short and it's keeping the tongue from lifting up, and it's completely just obvious. Those are the ones where doctors are like, oh yeah, there's a tongue tie. Surprisingly, an anterior tongue tie, I've seen a lot of babies compensate really well with it. Like, they can actually feed really well. They just end up feeding for a long time. And they maybe feed more frequently. A posterior tie is when that frenulum is deeper underneath, and you might not actually see it. You have to actually push underneath the tongue and lift it up to see it. And it's short, it can be thick, but what it does is it prevents range of motion in the tongue. So think of the tongue, like if I were to divide it, the front part of the tongue, if I divide it into thirds, there's a front anterior third, then there's a middle, and then towards the back is the posterior third. So posterior means towards the back. If there's a tie that is deeper and it prevents the back of the tongue from lifting, that's typically what we'll say is a posterior tie. So I think we call it that way, call it posterior tie because of the part of the tongue that it affects, whereas the anterior doesn't allow the tip to move around. Mm-hmm. I like to call it more of a submucosal lingual restriction. And I think a lot of other people would agree with that too, but it's easier for a lot of people to just say anterior, posterior tie. Mm-hmm. Yeah. Typically, posterior ties typically cause the bigger problems. Baby can't feed well, but it also looks like low muscle tone. And that's why I rely on therapists to evaluate function so we can really see, like, is this a neurological thing? Are they not lifting the back of it because of the tie? So they do the therapy, they get stronger, and then they hit a plateau, and then we know, okay, that's when we do the release.
Mm-hmm. So it's more than just like going and getting it checked and being like, oh, there's a release, we're going to do it. Yeah. 'Cause I mean, I was a part of a lip and tongue tie group on Facebook, and so many people had so many questions on there about, like, basically they're like, yeah, you have a tie, and they did it, but they never told them that they needed to do therapy or do anything following. Obviously they told them to do the stretches and all of that, but, first, before we go into that, like, is there a better way between cutting it or lasering it?
This is interesting. I just had a conversation about this with some colleagues on Facebook. And somebody, I actually had a situation where one of my pediatric dentist colleagues did do a release with scissors, and the baby was still having issues, and this baby had a posterior tie. My colleague was like kind of on the fence of doing it. He's like, I'm not sure if this will help her, but he did it. And she went to see a therapist later on because the baby didn't get better. And then the therapist said, maybe he didn't do a full release. Maybe go back and ask him. So she went back and asked, and she demanded that he redo it, and he did against his own judgment. And sure enough, she still didn't get much better. And then she came to me for a second opinion, and I looked at it and it healed really nicely. And she was like, he didn't use laser and wanted to be mad at him for this. And I said, you know what? There's no difference in healing between, well, there's some difference between scissor and laser. And there needs to be an understanding of the different types of lasers out there. And I'll get to that in a moment. But between scissor and CO2 laser, which is what I do, the difference is that in scissors, I have to give an injection of anesthetic and then cut, and there's a lot more bleeding. With the laser, I'm ablating the tissue. And I only place a topical anesthetic. So less bleeding, no injection. I like it for that reason, and I can do a clean cut and actually see what I'm cutting. So I can cut the individual fibers and ablate the tissue as I go. Now there's a misunderstanding out there that, oh, you want laser, but moms need to be very mindful of what type of laser it is. I've used them all. I've done scissors, I've done diode laser, and I've done a couple different CO2 lasers. Now the diode laser is not really a true laser. It doesn't ablate the tissue. What it is it's a laser beam that heats up a glass tip. And when the tip touches the tissue, it kind of melts it in a sense. It does cut, the tissue does end up separating, but it's through heat. There's a lot of heat dissipation. My experience with that has been babies going on feeding strikes after the release because they're in so much pain is what I'm guessing from the heat dissipation. I've experienced that enough to decide I would rather do scissors than do a diode laser. So even though there's no bleeding with the diode laser, that glass tip and that heat just doesn't bode well in the healing process. So I think there's a lot more damage to the surrounding tissue because of that. So CO2 laser is an actual laser beam that shoots out, goes into the cell of the tissue and causes it to burst. So you get true vaporization, ablation of tissue, and the tissue, vaporizes. It goes away. And I can actually watch the fibers separate and release and see that the laser beam goes exactly where I want to go. And there's no bleeding, very little to no bleeding at all. And because of this specific type of laser, I use the light scalpel. There's no energy dissipation that causes any post-operative pain. And most babies do well. Once in a while, they have a hard time with it. I think that some babies are going to be more sensitive than others, just like adults. I am way more sensitive than my sisters. So you're going to get that sometimes, but for the most part, a CO2 laser is my tool of choice. That is what I use because of no bleeding, no anesthetic injection, and post-op healing and care is so much more tolerable for the baby.
Mm-hmm. Yeah. I was actually surprised at how well my daughter Jovi did. The first couple of days were kind of, I think it's more hard for me because your baby is crying because you're sticking your fingers in their mouth and doing all these things. And they're just leave me alone. But then I got to a point where I kind of would make her laugh and do it. Except for in the middle of the night, obviously those ones were still miserable, but it is hard on the parent, you're but I didn't feel like she was in that much pain. I felt like it was more the annoyance of leave me alone.
What did she have done? Did she have scissors or?
She had the laser, the one that you were talking about.
Okay. Awesome.
Mm-hmm.
That's generally what most parents will experience. And I love that. Most of the time you're right. Parents are going to be more nervous about doing it than the baby. The baby can handle it. And so I always have to remind moms okay, listen, when you take your baby home and you do these stretches, they're going to cry. Just remember that. The important thing is that they get over it really fast. And you're going to find as soon as your fingers are out of their mouth, they're good. They stop crying. And then they're like, okay. And like, so just hang on to that so that you don't feel bad about doing this, because it has to be done, because we don't want reattachment, which does happen. I've seen.
Yeah, I've heard of that too. And that also just sounds horrible. Oh, I can't imagine if hers reattached and then you have to like, when you're telling that story, that mom who like had him redo it, I'm like, oh, I would just hate to have to go through it again.
It's awful. It's not, I don't want to say it's awful. We try to make it as good an experience as possible. And I give my cell phone number to all my patients and I let them know, like, just text me, even if it's 4:00 in the morning and you're like unsure about something, message me, reach out to me so I can give you some peace of mind, because that's usually what new moms need, is just some peace of mind. But
is there, have you seen cases where people come in and maybe they don't need it released, they might just need some therapy or something else?
Yeah, absolutely. And that's why I send them to the therapist first, because you just never know. You never know if they're going to respond well to the therapy or not. Typically, I've gotten really good in my assessments and knowing when there's a tongue and lip tie. And so if I see it there, I'm like, okay, well, we'll probably have to do this, but I'm still going to send you to therapy first before we do the procedure. And I've had babies come in where I feel their frenulum and I'm like, nope, it's not a tongue tie, but I know what's going to help your baby, and that's therapy. And then that helps. Then they go to therapy and usually there's more going on. The body might not be strong. They have to work a lot more on tummy time. And so the therapists are really good at that. But the oral motor exercises are super beneficial for these babies. And not everyone knows how to do it. I only have a handful of people I can refer to throughout Los Angeles, like 10 million people. And I only have a few that I can send to that know how to do it well. And if there are any out there, I would love them to reach out to me if there's any that I don't know about, because these moms need it. And unfortunately, most of the people who do know how to do it don't take insurance. That
was going to be the next thing I was going to say, is like, my insurance covered one person that I went to, but I ended up switching to somebody else and we had to pay out of pocket. And I'm in the process of actually right now submitting it to my insurance just to see if they'll cover any of it, even though this happened like 5 months ago. So that's the thing that just sucks with it, is like, insurance doesn't always cover everything. Insurance didn't cover most of her release either, even though the pediatrician like gave the order or whatever, was like, you should get this done. And so for some families, it's just not financially doable either.
It's not, and it's really tough. You're actually making me think about one of the things that's always on my mind. I'm like, I need to create a nonprofit to like help these families be able to get access to the right people to do this. Because I mean, somebody like me, my fees are high. They're not low. And it's because I do put a lot of time and energy into my families. I do follow up with them closely. I don't charge for the follow-ups, and I want to make sure it's successful. But the amount of education and knowledge, and money and time I've invested into being able to learn how to do the right thing and to do it well for my patients, it's really tough. It's like there's more to it than just doing the procedure. I'm speaking to all of the therapists that I send to. I'm always in contact with them, because you have to do this team approach. And so there's a lot of time that I spend outside of what I spend with the patient in the room. And it's tough. And so if I were to take insurance and they didn't reimburse me, which I've had that before, I tried it in a dental office and we took insurance, because I'm like, I'm going to take insurance. All these people who do this don't take insurance. I'm going to do it for these babies. And then I was realizing they're reimbursing me like $150 or $200 for it. And I'm like, I put way too much into this. I deserve way more than this. And it's tough, because once in a while I do get families that can't afford it. And through the community that I work with, sometimes I do get families like that, and I'm happy to help them out and give them a break or give them payment plans and make it easier for them. But if I took insurance, I wouldn't be able to do that just because of how insurance laws work. If you're in network, you can't give discounts to people who are paying out of pocket, and there's a whole legal thing behind that. But so I would love to help families, and I'm not the only provider who does this. I mean, there's other providers who do this the same way, and rightfully so. They should get paid for the time and work and care that they put into these families and these babies. But it would be nice to have something that will help all the families that don't have access to this sort of care. It's constantly on my mind. So, and it's not just that. It's not just me. I'm just one component. There's therapists. I send them for body work. They see the chiropractor. They see the craniosacral therapist. They see the speech language pathologist. They see the occupational therapist. Sometimes they see the physical therapist. And it's a lot of time. It's a lot of appointments. It's a lot of energy. And then the parents have to do the exercises when they're at home. And it can be exhausting. It can be a lot for the families, and they can get burned out. So we try to be super mindful of that. And that's why I approach it the way that I do, and want to be supportive of these families and make it feasible for them and not make it too hard or overwhelming. Mm-hmm. But it can be. Did you do all of that? Did you go through all the oral motor therapy and body work?
We did. So we went to like a speech and language pathologist. And then I went to a myofunctional. She went to a chiropractor and then did the myofunctional therapy. Yeah. And I don't know, that lady did something else too. But she would basically kind of like, do these like mouth adjustment things and then tell me like a few things to do at home. But that was it.
Yeah. I think my therapist, and this is a very new thing with how to do this properly. And there's not a ton of research and understanding around this yet. But there will be, the therapeutic part of it is something that I would say not a lot of people do. And I think a lot of providers that do tongue tie releases are not sure how to recommend it either. It's not like I learned it in dental school. I did not learn this in dental school. I've spent time with my therapist. I go with my patients to their appointments sometimes, and for me to learn, and I watch the therapist provide the therapy, and I ask them questions like, what are you doing? Why are you doing this? What is this exercise supposed to do? They're telling me about how, doing this exercise is going to help with jaw stabilization. Doing this exercise is going to help with posture of the tongue. And doing this is going to help, get the tongue to lift up. They teach me so much. And that's why I've come to do my assessments in such a way where I'm like, I'm not going to do the tongue tie release, because I'm starting to learn and realize there's so much more to this than just the procedure itself. And so, and can therapy help? Can therapy alone help? Sometimes it does. And sometimes moms decide to bottle feed. And if they're going to bottle feed, I might not do the tongue tie release. I might wait until later because of how the healing works. It relies on parents doing the stretches. And if reattachment happens, when they suck on the bottle, it's a different type of suck, different function of sucking versus the breast. The tongue stays low. And so chance of reattachment is going to be higher if they're on a bottle and pacifier all the time. So this is my change in thinking over time. I used to say like, oh yeah, let's do it. It'll help them. But now that I'm seeing how healing is happening, and when the way healing happens for an open wound versus later on when they're 2-3 years old and I'm putting them to sleep, I'm doing more what's called a functional frenuloplasty. I'm not just snipping and removing the frenulum with laser. I'm actually suturing them back up together. And it's a different type of healing. It's healing by primary intention. And so that healing by primary intention, allows for them to not really have to do the stretches and exercises. And it actually moves the frenulum back, and it changes the anatomy of it. So there's a lot of things that need to be learned and understood still in this realm. And that's why there's a conflict between all pediatricians out there where they'll say like, yes, it'll help, or no, it won't help, because the research shows that there's only a 50% success rate. And in medicine, that's low. You don't want to do something, you don't want to do a procedure that only has a 50% success rate. I don't want to do that. And so if I want it to be successful, I'm going to put all my time and energy to making sure that we're addressing it from all angles before I do the procedure.
Mm-hmm. Yeah. I know that the pediatric orthodontist that we went to, you have to have an appointment at a therapist in order to get the release done. Like he won't just do it. He's like, you have to, they recommend you start going before, and then you have to have an appointment set up for, well, we had a same day appointment. And then I don't remember, it was like the next day or something, like set up before you leave the office, because he's like, they're like, we want you to do it in combination.
Yeah, absolutely. It has to be timed properly. Like, the orthodontist needs to expand. We're not going to do the tongue tie release until the tongue has enough strength and endurance to be able to do the procedure. Because to do the procedure properly, with the functional frenuloplasty, for me to get underneath the tongue and remove all the bands of tissue, the patient has to perform certain exercises during the procedure. They have to suction their tongue up. They have to be able to extend it. And this takes time and it takes energy. And if the patient's tongue is too weak, they're not going to be able to do it well. And if they can't do it well, I won't get a full release. I've done it before in the past, and we'd have to redo the surgery again later on. It's just not worth it. And so when you're going to a great orthodontist, the fact that they look at it this way and they tell you, nope, not going to do it unless you do the therapy first, that's amazing. That's absolutely how they should approach it. And if that is their approach, they know what they're doing. Mm-hmm. So that's how you know they're the right person. You're with the right person, because the providers who are kind of like, let's just try it and see, they might not know. They might not know that there's a better way to do this for, a better outcome.
Mm-hmm. I was going to ask you too, because at the beginning you were saying that breastfeeding has benefits to the way that your face is developing. So for people who aren't breastfeeding, is there a bottle that they can do or something else that they can do to help with that facial development?
That's a tough one. That's a thing I would maybe defer to my assistants. One of the things that's really tough about this is when they've already developed with a very narrow palate. Sometimes when we do a tongue tie release, because the palate is still so high and narrow, they still don't feed well. And then they end up on bottle because bottle is easier. There really isn't much we can do. Now, there are some providers out there that will do something called an ALF, an advanced light force appliance. And it's kind of like having a retainer up in the roof of your mouth, and you add to it a little bit to help expand the palate for the baby. But it also kind of fills in that airspace up in the palate and allows them to feed easier. It's kind of a very new and very progressive thing, and I'm considering learning more about it, because I'm finding there are some babies that I do releases for, and they still have a tough time because the palate is so high. But body work, there really isn't too much you can do functionally to help with that palate. I think the best thing you can do to do something to help is to encourage proper oral rest posture. So encouraging the tongue to stay up and when the baby's sleeping. So it's actually one of the exercises I give, to all of my parents. I'm like, when your baby's sleeping, after I do a tongue tie release, I want you to close their mouth, make sure their lips are together, they're breathing through their nose, and then press on their chin. And when you press on their chin and open their mouth, make sure their tongue is suctioned up to the roof of their mouth. And I want you to open it as wide as you can. Keep pressing and pressing and pressing until they're the widest, until they let go of their suction. If they have really good range of motion and really good suction, you're going to be pressing on that chin for a while, and they're going to be open wide before the suction lets go. And that's a really good thing. And then I have them reestablish, close the chin back together, close the mouth, close the lips, rub underneath the chin, because that's the belly of the tongue, and it gets the tongue to go up. So that that oral rest posture, I think, is one of the most beneficial things that you can do.
Mm-hmm. But is there like a good bottle that helps or not really? Because you get all that, like, because like I've seen before, it's like you want to use this bottle, you want to use that bottle. This bottle encourages this and that bottle does that.
My feeding therapist will know that answer better, but I guess if I really think about it, the bottles that mimic breasts the most might be the most beneficial. But if they're tongue and lip tied, they won't be able to use that bottle. They'll have a much harder time with that bottle. So yeah, I'm not a big bottle person. Like, I don't know it as well as I should because I always defer to the lactation consultants and my therapist when it comes to that. They know them really well. So I'm gonna connect you with one of those people and they'll let you know more about that.
Yeah, for sure.
Sucking, how to address those things.
Mm-hmm. Yeah, I saw something the other day that was like, you don't want a bottle that looks like a breast. You want one that looks like a nipple. And I'm like, man, there's just way too much information out there about this.
All the conflicting information, right? There's a lot out there, and that's why it's hard for me too. And so I can't, if I'm not the expert in it, I'm not going to make a recommendation in it. And so I always defer to my therapist and like ask the speech language pathologist who works with infants. They will let you know, or ask the lactation consultant. They will probably know whether or not it's going to affect their growth and development and help with that. I can't say, but if I can find out the answer to that, I'm gonna let you know. Now I'm going to be thinking about this for the next few weeks.
Yeah. I mean, like I said, it just, sometimes it's like an overload of information out there. I guess like for people listening before we wrap up, what are a couple of just really common signs that their kid might have one, that they might want to go get it checked out?
Yeah, it's a very good question. On my intake form, a lot of the questions that I'll ask is going to be around, like, does your baby fall asleep on the breast? Does your baby slide off the nipple while they're feeding? Is the latch shallow? Are they colicky? Do they seem extremely gassy? Are they having poor weight gain? Those are typically things. How frequently are they feeding? How long are their feeds? Typically, I would say those questions, they're general questions, and I don't like to say like, oh, if they're feeding frequently and they're falling asleep every time, it's because, or, oh, here's another one, clicking. If they're clicking, these are things that can happen when there's an oversupply and a really strong letdown too. So really understanding that is important. Now, the unfortunate thing about that is when there's an oversupply and mom changes position and it kind of helps, but baby's still struggling. If they seem frustrated at the breast still, that's why I have them work with lactation consultants first. We figure that out. And if the baby's still having issues, then there's likely a tongue and lip tie component or issue with that. Leaking from the sides of the mouth means that they don't have a good seal. So the lip tie could be a reason for that. Or the tongue has poor control and so they can't swallow the milk. Mouth breathing is another indication that there could be a tongue tie because the tongue is staying low, so the mouth wants to open. And when the tongue is low, it's back. It closes off the airway more. And so it's easier for them to breathe through their mouth. I can't tell you how many babies, after I do tongue tie release, they breathe better. It has one thing parents are like, wow, I don't hear them breathe anymore. Like they're sleeping and I have to check on them to see if they're breathing because they're so quiet now. So, yeah, those would be the most typical things to look out for. And unfortunately, so many things can cause those things. Gassiness could be a diet thing, could be that they're lactose intolerant. There's a dairy allergy, gluten allergy, egg allergy, mom changes her diet. So these are things I really look into first. I ask a ton of questions and really dive deep into each of these symptoms and figure out if it really is a tongue tie issue or if there could be something else going on. And sometimes it's both. Sometimes they have to target all of it. But yeah, that's pretty much what helps.
Yeah. Well, you sound like you're awesome at your job, because I mean, just based from like the Facebook group that I was in, I feel like not many pediatric dentists do it the way that you do, and are kind of a lot more probably just like invasive, like, oh, yep, there it is, clip it, whatever, let's go. Instead of kind of taking that holistic approach. So thank you for caring so much about your patients.
Thank you. I love what I do. I really find a lot of joy in this, and there's nothing more rewarding than helping a mom establish her breastfeeding experience with her baby. So it helps me so much. It brings me so much joy that I'm like, I'll keep doing this for so long, for forever.
And then before we end, is there any good resources, I guess, out there? Is there like a website that people could go to or anything like that to learn more, or to like, I guess, educate themselves?
I'm trying to provide more resources through my Instagram and on my website, drtracytran.com. I have some information on there. I do need to make it better. But the Breathe Institute is also a great resource. Dr. Chelsea Pinto is there. She's a wonderful dentist, and she just treats infants. But then Dr. Zaghi sees the older children, and so he does a lot of research with tongue and lip tie. And the IAOM, the International Academy of Orofacial Myofunctional Therapy, they know a lot. They're all of the therapists, and they might have some resources there for moms and parents about myofunctional therapy. So for older children, not really for the infants, but they might have some resources for infants too. Michelle Emmanuel, she is a occupational therapist who works a lot with babies with feeding issues. So she's a great resource. I think she has some things on her website. I can give you a whole list of things. I'll send it to you.
Yeah, perfect. Yeah. And then I'll post that. So for anybody listening, I'll have some resources in the show notes of the episode. So I just want to thank you so much for taking the time to come on and to educate us and to share all about ties and your work and what we can do to look out in case our kids have them.
My pleasure. Thank you for having me.
All right. I hope that you enjoyed the episode. Like I said, if you didn't listen to last week's episode with Tatiana from ICANN, definitely go back and listen to that. Next week, I've just recorded so many good episodes lately that I cannot wait to put out. I believe we're having Ayana on. She's a midwife in LA, and we're going to talk about the birthing crisis in America. And it's just a super empowering episode as well. If you guys are listening and you're not following us on Instagram, make sure that you go follow Miraculous Mamas, join our Facebook group, and also leave us a rating. Let us know what episodes you've been loving and why, and reach out. Let me know who you want to hear from and what you want us to talk about. I get so many great topic ideas from you guys. And just so you know, I always look into it. Sometimes it takes a while to find the right person to speak to the topic. I want to bring somebody on who's an expert, who's knowledgeable. And sometimes it's hard getting in contact with those people and finding the right people or waiting for a response from those people. So if there's somebody else that you guys want on, tag me, in their social, post on their stuff, say, hey, go on the Miraculous Mamas podcast. Let them know that you want to hear from them on here as well. All right. I hope that you guys are having a great April so far. Spring is here. It's getting a little bit warmer, which is so nice to be able to go outside and get some sun with Jovi. So I hope you guys are taking in that vitamin D. All right. Love you guys. Talk to you next week.
If you want to be the most interesting person at the cocktail party, well, hop on over and listen to the Brain Candy podcast.
Our award-winning content will have you laughing while you're learning.
We read all the best articles, books, and studies and keep up with new TV shows, documentaries, and pop culture. And then we cram it all into 2 shows a week.
Conspiracy theories, cannibal rabbits, unsolved mysteries, the history of the Walkman. There's something for everyone.
The Brain Candy podcast. Find our link in the show notes.
or simply search for the Brain Candy Podcast on your podcast app.